Good afternoon. My name is Adrian Dix. I'm BC's Minister of Health. To my right is Dr. Bonnie Henry, BC's Provincial Health Officer. It's our COVID-19 briefing for British Columbia for Tuesday, March the 2nd. We're honored to be here on the territory of the Lekwungen-speaking people of the Songhees and the Esquimalt First Nations. Tomorrow, Wednesday, we'll be providing a briefing or a written briefing at around 3 o'clock with relevant information about COVID-19 in British Columbia, including case counts. On Thursday in the early afternoon, we'll be doing a briefing and our regular update in person here at the Press Theatre in Victoria. And with that, it's my honor to introduce Dr. Bonnie Henry.
Thank you and good afternoon. Just to start off with today, we've been having, as we noted in our statement, some challenges with the data system that we put into place early in this year in terms of our daily case counts. And over the past 7 days, this data system has been system issue has been resolved. And over the last 7 days, there's been an additional 254 cases that needed to be counted in the system. And those will be reconciled on the BC CDC dashboard by later today. So if you notice a discrepancy, for those who follow those numbers, that is what it is due to. And so for today, there are an additional 438 new cases, including 9 epidemiologically linked cases in the last 24 hours. So that does not include the 254 cases over the last 7 days. But that does bring our total up to 81,367 people in BC who've been diagnosed with COVID-19. And for today, that includes 137 people in Vancouver Coastal Health, 249 in Fraser Health Authority, 19 people on the Vancouver Island Health Authority area, 16 people in Interior Health, and 17 people in the Northern Health region. We now have 4,679 active cases across the province and 243 people in hospital, 63 of whom are in intensive care. We have 8,445 people under active public health monitoring, but 75,255 people have now recovered. In the last 24 hours, we have had 2 additional people who have died from COVID-19, bringing the total number of people who've died in our province to 1,365. As always, we do think of the families and the caregivers and the communities who will be mourning these 2 more people who've died in this pandemic. We have 2 new healthcare outbreaks, one at the Chartwell Carrington House retirement residence and independent living residence, and another acute care hospital at the Eagle Ridge Hospital, one ward there. And the Eden Gardens outbreak has been declared over. We now have 8 active outbreaks in long-term care or assisted living and 8 in acute care settings. Of the people in long-term care, that includes 293 residents and 156 staff who are affected. In terms of the variants of concern, an update on those, we have 22 new confirmed cases, bringing our total number of people with variant infections of COVID-19 to 182, 8 of which are now active cases. The remaining people have resolved or are no longer infectious. And right now that includes 159 people with the B117, the one that we're most concerned about, increased transmissibility, and 23 with the B1351, or the one that's associated with South Africa. The majority remain in the in the Fraser Health region, 124, and 50 in the Vancouver Coastal Health region, and there are no increases in the numbers in other health areas. 9 cases overall have been hospitalized, but only 1 person is currently in hospital. And we know that we pay close attention to these cases to try and determine where and how people were infected. About 13% are directly related to travel, and 60% are close contacts. But there are still 20 to 25%, a quarter of these cases, where we are not clear where they acquired the source. And that reflects that we have transmission going on in communities, particularly, as we know, in the Lower Mainland. Since the start of our immunization program in December, we now have delivered over 283,182 doses of a COVID-19 vaccine, 86,537 second doses as of yesterday. And as you know, we have now made the determination that we will be extending the dose interval between a first and second dose starting today, and that extension will be up to 4 months. Yesterday, as you know, we've reported on, we've begun phase 2 of our COVID-19 immunization program that will, in the next month, see over 400,000 people in British Columbia immunized. And this is an incredibly important next step in our program. This continues to focus as well, particularly this week and next week, on our high priority, higher risk individuals and groups. And then our first broad age-based population group, those most at risk, are seniors and elders 80 years of age and above. As you know, this pandemic has taught us a lot. We continue to learn about the virus, about how it's transmitted, and to review and adapt our approach based on scientific evidence and real-world data. So what we see from trials, from studies, and then what we actually experience in the real world. And we also, that has what has underpinned our immunization program, where our experience in communities here in BC that reflects what we're seeing around the world clearly shows us that the older you are, the higher your risk of having more severe illness or dying. We've also learned that outside of the lab, on the ground and real world, the initial dose of the approved vaccines that we have here in Canada are highly effective. Our goals, as I talked about yesterday, have always been to reduce morbidity and mortality, so to reduce sickness and death from COVID-19, to protect our healthcare system so that we can provide those necessary services to everybody who needs healthcare, and while doing that, to minimize as much as we can the disruption that this pandemic has made on our community and our society. The vaccine strategy that we have approached, or that we are taking, is the one that maximizes the greatest benefit to our whole community. And in our context right now in Canada and BC of our limited supply, as cases continue to increase and we have transmission and outbreaks in our community, our focus is on maximizing the number of people who are benefiting from that very high real-world protection that we are seeing from a first dose of vaccine in BC. This new data that we have been following very carefully since the immunization program started around the world shows that we have sustained high levels of protection against illness, hospitalization, and deaths from one dose of the 3 approved and effective vaccines. We are following the science of vaccines. We have been following vaccine efficacy, and that's what we get from the clinical trials that are done under specific controlled conditions. So we know that anybody with certain conditions are ruled out, are not included in those trials. Those trials were also using an interval that maximized our ability to get the information about whether these vaccines worked and were safe as quickly as possible. And that's why they used as short an interval as they could possibly use, in most cases 3 to 4 weeks. We also use the science of immunology, how our body's immune system adapts and uses and responds to vaccines. And this is a field of study that we have had for many, many years, and we have a lot of experience from other vaccine programs. And we know that it takes time for our body to develop antibodies and for our cell-mediated immunity, the second part of our immune system, to be stimulated and active so it can respond if you're exposed to a virus. We also now have started and are using the data that we get from what we call effectiveness. So efficacy is that trials, the clinical trials where everything is very rigidly controlled, and effectiveness is the real world experience of what we're seeing when we use these vaccines in people in the real world. And we have been, from the very beginning, we have a great team of scientists at the BC CDC who have been doing this for many years in terms of influenza, looking at pertussis, all of the immunization programs that we have, and understanding the vaccine effectiveness. How well do these vaccines work in our populations in BC, in Canada? And that's led by Dr. Danuta Skowronski at the BC CDC and her team, and Dr. Monica Naus. And we have a lot of experience in this. And from the very beginning of our COVID vaccine immunization programs, we put in those studies, those real-world population studies, to understand the effect of these vaccines in our community. And we focused on the people most at risk in long-term care and healthcare workers. And that data tells us that the effect that we're getting, the benefit and the protection from a single dose after about 3 weeks, is upwards of 90%. And that lasts for a long time, at least for several months. So that is the type of information that we need to make those important decisions about what is the best way to maximize benefit. Plus, we add in data modeling, which helps us understand who to immunize first and when's the optimal time to have a second dose given the vaccine supplies that we are receiving over the next 4 to 6 months. And we've used the basics of what we call immunology, the body's immune system response, and vaccine science. And that is why I am so confident that the decision we made over this past weekend to extend that interval is the best one based on all of the science and the data that we have to maximize the benefit to everybody in our community here in BC, so that we can both stop people from getting seriously ill, prevent people from needing hospitalization, and prevent people from dying, as well as getting well on our way to being able to reduce this disruptive restrictions that we have to put in place to prevent transmission of the virus in the near term. So we are now looking at months rather than many, many months before we can reach a level where people have enough protection. And the other part that we need to remember is that for everybody who's immunized, for the more people we have immunized in our community, the less probability that the virus has find somebody it can transmit to and pass on. And that protects all of us. So it magnifies the effect of an individual protection. And we know the positive impact of this goes further than even every individual that's vaccinated. So we know that the risk of passing the virus on to others is dramatically decreased. So it's added protection to all of us, to our communities, our families, and everybody that we're around. And this is what we call a vaccine multiplier effect. And we know now with the newly approved Astrazeneca Serum Institute of India viral vector vaccines that we have yet another safe and effective vaccine that will help us accelerate that effect by providing vaccines we're looking at essential workers and frontline first responders. While we don't know yet what our supply will be, this means that we can move everybody up the line and we can provide protection to those in our community who have shown up for work every day throughout this pandemic, and we can protect them, their workplaces, their families, and their communities. This is encouraging news for all of us. There is light ahead, and it is getting brighter every day. But we are not yet there, and we need to remember that particularly now, as we're ramping up this program, we need to continue our levels of protection and not put aside those public health restrictions quite yet. We have to have the confidence that we are slowing the spread in a sustained way to stop easing our restrictions. But with this rapidly increasing number of people being immunized, that is going to happen sooner. And that means we can reduce those restrictions and increase visits in long-term care much sooner. and we can increase our social interactions sooner. Those are the things that are going to be important. We now know from the real-world data that we don't need to rely on second doses before we can lift some of these restrictions if we have enough people protected and we can stop that transmission in our communities. So that is our goal right now. And when we by the time we get to the end of June, July, where we have everybody protected with a single dose, we will know more about when is the optimal timing for a booster dose. Do we need a booster dose that will help us deal with some of the variants that we're seeing in other parts of the world? All of that science is going on now, and by the time we get through these next few months, we'll have a better idea about that, about what we need to get us through the next respiratory season and the next few years. But right now, we know that maximizing the benefit of a single dose for more people in British Columbia is going to get us to our post-pandemic goal sooner, and is going to protect more people, keep more people from needing hospitalizations, and prevent more people from dying. This means right now we need to stay committed to using our layers of protection, to stay small, stay local, and remember to continue to be kind, be calm, and be safe.
Thank you very much, Dr. Henry, and I wanted to start by passing on my condolences and thoughts to the families, the friends, the caregivers of the two people who passed away from COVID-19 in the last 24 hours in British Columbia, one in the Fraser Health Authority, one in the Northern Health Authority. This continues to be, and we reflect on this, a very difficult time to suffer loss, and we are thinking of you today and wanted to pass on, really on behalf of everyone in BC, but on behalf of the Premier and the government as well, our thoughts and our condolences to everyone involved. Wanted to just say with respect to the immunization campaign, as Dr. Henry has said, 283,182 doses, 186,654 different people have received first doses, 86,537 have received second doses to date in BC. So I want to note how significant that is now in long-term care. 95% of residents, or 29,484, have received their first doses of COVID-19, and many more their second doses. 97% of our target for workers in long-term care, which had been 39,000, that's 37,790 such workers. 60,164 frontline social workers, 5,740 essential workers, 15,199 community healthcare workers, 751 people waiting for long-term care who are generally in acute care hospitals, 748 as we start providing care to home care recipients. All of this significant, all of this already occurred, and all of it makes our healthcare system safer, and you have seen the results in long-term care. Today there are only 6 remaining outbreaks in long-term care, and I just want to thank all of the people involved in this so far. This is involved because the long-term care and the assisted living clinics have all been individual clinics all over the province, more than 1,000 different locations so far. This has involved an extraordinary effort by healthcare workers, by people who work in care homes, by the residents themselves, by everyone involved to support this effort. And all I feel towards everyone involved is a real sense of gratitude. This includes many people in rural and remote Indigenous communities as well, in First Nations communities in particular all across the province, because that is a significant part of our plan as well, and has involved tens of thousands of people receiving their first dose immunizations. I wanted to just respond to a question that I got a fair amount through email last night from self-advocates, people living with disabilities, people living with developmental disabilities. I just want to note that the Office of the PHO, I think it's Deputy Provincial Health Officer Daniel Ben-Smith, regularly meets with organizations representing people with disabilities, including developmental disabilities, and are very aware and very focused on the particular challenges faced by these groups. The Provincial Health Services Authority in particular Maureen O'Donnell, a vice president there, who has been working on this file, has been working hard to deal with the issues around prioritization in the vaccination program. Some people who are living with disabilities will be receiving or have received, been prioritized in our current phase of our immunization plan, depending on where they reside. For example, people with disabilities in group homes will be in phase 2, which are vulnerable populations living and working in select congregate settings. Adults with very significant developmental disabilities that increase risk to COVID-19 are prioritized in phase 3 of the plan under the category people aged 69 to 16 who are clinically vulnerable and will be immunized at the same time as people who are 74 to 70 years old, and that will be in April. Making immunizations available to these groups will be coordinated through specialty clinics and medical providers. So I wanted to pull up to date of that. Obviously that information is available, but we have an extraordinary community, a vigorous community of self-advocates and families who advocate for family members. So I wanted to just make sure that people had that information. I wanted to note that we will be providing in the statement information about PPE that's arrived in the province over the last couple of weeks, and those who are interested in that can look to the statement for that information. I think in closing, I want to say that there are certain words that mark good days in our BC pandemic, days when we hear and read that vaccines have been approved, vaccines have arrived, and people are getting their shots. Simple words and short phrases that are enormous in their meaning and their power to renew us. We know that our collective work is not over. We understand that our individual duty to stop the spread and save lives continues. It is as important now as it has ever been. But Friday's news of Canada's approval of a third vaccine, along with the key parts of our immunization commitment presented yesterday and that Dr. Henry has spoken of today, these stand as good days. And it is my hope that these good days provide each of us with restorative peace of mind, and that we can all take comfort in this welcome period, and with the understanding that other good days are going to follow. Aujourd'hui, nous annonçons 695 nouveaux cas qui ont testé, 400. J'ai ajouté des autres cas là-bas, les 254 nouveaux cas, c'est 438 nouveaux cas qui ont testé positif pour COVID-19, pour un total de 81 367 cas en Colombie-Britannique. Nous sommes attristés d'annoncer 2 nouveaux décès liés au COVID-19 pour un total de 1365 décès en Colombie-Britannique. Nous offrons nos condoléances à tous ceux qui ont perdu leurs proches pendant cette pandémie. Comme vient de dire la Dr. Henry, on a ajouté pendant la dernière semaine 254 nouveaux cas qui n'ont pas été considérés avant, et ces cas-là vont être ajoutés à nos total des cas. Parmi l'ensemble des cas confirmés de COVID-19 en Colombie-Britannique, 243 personnes sont actuellement hospitalisées, dont 63 en soins intensifs. Merci beaucoup. Thank you very much. We're happy to take your questions.
Thank you, Minister. As a reminder to everybody on the phone line, please press *1 to enter the queue. You will be limited to 1 question and 1 follow-up. I would also ask that you please take your phones off mute. You are not audible until your name is called. First question today is from Rob Buffum, CTV VI.
Oh, hi. Thank you for taking my question. Dr. Henry, I guess what I'm wondering, and you did lay out in a great deal of detail the rationale for the 4-month time period, but I'm hoping you can react to the criticism that you might have heard from Canada's Chief Science Advisor, likening the extension to basically a population experiment in the absence of clinical data. And I know Dr. Fauci in the States has also recommended against extending that time period. Can you just respond, I guess, specifically to those criticisms?
And I'll start with Dr. Fauci, who I think you have to read the entirety of what he said. And it was that he did not recommend the extension of doses in the United States because he felt they had sufficient vaccine that they could use that same time frame, which is fine. And he also went on to talk about the fact that he had regular meetings with the UK. The UK is using a similar time frame to what we are. and they have extended the interval between first and second doses, and have from the very beginning. And part of the data that we use to understand the real-world effectiveness of the vaccine came from the UK and came from the experience that they're having there, that a single dose is very protective. And Dr. Fauci went on to say that each of those approaches is correct and is right and works for them. And we are in a position where we are looking at the data from the UK, but we're also in a position that's quite different from the US in terms of our vaccine availability in the short term. And we are at a position where we still have ongoing transmission in our communities in quite a serious way, particularly here, Ontario, a number of communities across the country. So this makes sense for us, knowing that it is a critical time right now with the limited amount of vaccines that we have in the coming weeks to be able to provide that protection that is safe and long-lasting for in the short term, so for several months, to everybody here. And that is why we made the decision that we did. It is a little bit unfortunate that the National Science Advisor, who, obviously was not involved in some of these discussions and decision-making, and perhaps didn't understand the context that this decision was made in. So it is absolutely our intent to continue to do the studies that we are doing. And I mentioned this from the BC CDC, the vaccine effectiveness, to make sure that we are monitoring carefully for making sure the vaccine is working and that level of protection continues in our communities, and help us understand the level of protection that we achieve when we immunize more people more quickly. So that's how we made the basis of our decision. I will also say the National Advisory Committee on Immunization, which is an independent body which looks at immunization programs routinely, will be coming out with a statement shortly.
Rob, do you have a follow-up?
I do. I guess I'm maybe a two-parter, but I'm just wondering about, in yesterday's presentation, as I understood it, you sort of referenced that there in fact may be a benefit to there being the extension to 4 months. You talked about international data, as well as from Canada, talking about a benefit to extending the dose, the second dose, to 4 months. So do I understand correctly? Not only may this be a compromise that's necessary, but one that may come with benefits. And I don't know if you're also able to answer. You mentioned end of June is when everyone may have a first shot by now, which seems like it's even more positive than yesterday's news.
Well, if we look at just Moderna and Pfizer and what the amounts that were scheduled to receive, assuming everything goes as planned, it will actually be mid-July. But with the addition of Astrazeneca and perhaps soon the Johnson & Johnson vaccine as well, we may be able to move that up. So I was probably slightly over-optimistic, but we are looking at July. And yes, we know from immunology that the booster dose, the timing of the booster dose can sometimes confer additional benefit in terms of the strength of the immune response, particularly the cell-mediated immunity, and have a prolonged benefit in how long the response lasts. And we know this from other vaccine programs, particularly hepatitis programs, hepatitis A and hepatitis B, when we find that if you increase the interval, if you give it too soon, we know this from immunology and from vaccine science for a long time. If you give it too soon, your body's immune system just doesn't recognize it as something new. It's just a little bit of a bump, a stimulus of the first dose that you got. But if you extend it a period of time that's up to 6 months, for some things it can be as long as a year, but 6 months is a usual one, then you can get a more durable and longer lasting protection. We don't know that for sure yet. These are all new vaccines. And we've only been monitoring them for now close to 5 months for some of the vaccines from the clinical trials, etc. So those are things that we still have yet to determine, and those are the things that we're going to be watching, and we're going to be watching what happens. There's a mix and match study, as we call it, going on in the UK. So starting with one vaccine, looking at different dose intervals, giving having a second dose with a different vaccine to see if any one of those combination gives you longer lasting and better protection. So all of this stuff is new, and we're going to be learning as we go over the next few months. But we are confident in the decisions we've made right now, and we're going to know a whole lot more by the time we get to June and July.
Next question is from Justine Hunter, Globe and Mail.
Hi, thanks. Dr. Henry, I spoke with Dr. Mona Niemer today as well, and she's essentially calling on you to show your work. Don't just say that the data supports this change, but show us. And I'm just wondering if you're able to release some of the data that you based this decision on for the 4 months gap instead of, say, 3 months, which is kind of what you've been talking about before this week.
So we did present the data. Danuta Skowronski's published a paper. We've got it on the BC CDC website about the vaccine effectiveness. Quebec as well has published their vaccine effectiveness data going out for a number of weeks. There's data that's published in the New England Journal. There's pre-publications that we were able to see some of the data from the UK, and the National Advisory Committee on Immunization has examined those data in detail as well. So I am not obviously at liberty to publish that. There are some papers that have been in the literature right now from Israel. Plus, we've had meetings with them. So there is BC data that we are absolutely out there publishing, and I know Dr. Skowronski and her team have put a number of it up on the BC CDC website, and others are in publication now. But all of those data were examined by our immunization committee and by the National Advisory Committee on Immunization.
Follow-up, Justine?
Yeah, thanks. You said NACI will be coming out with a statement shortly. Is that today, or do you have an idea? Because I know a number of provinces are saying they want to wait and see what NACI advises before they upgrade their policies. Obviously, some interest in getting more people vaccinated sooner.
Yeah, absolutely. And I'm afraid you're going to have to ask them. I know it is imminent is the closest I can say. And that was obviously a topic of discussion by our Council of Chief Medical Officers of Health on our call on the weekend and again today.
Richard Zisman, Global News.
I'm just wondering if you are worried about the stability of future supply coming from Ottawa. And one of the things that was noted from Ottawa today was the Astrazeneca vaccine could come pretty quickly, 300,000 by as early as next week, but it expires by April 2nd. BC doesn't have a plan for Astrazeneca yet. Do you believe we can distribute that vaccine by that April 2nd deadline?
Yeah, so, we've now got confirmation from Pfizer out to the end of April. That came through today, so that's good news. Obviously, we are not the ones managing the contracts with the suppliers. That's happening through the National Operations Centre in Ottawa, but we know they have been working hard. And this is one of those things there, across the country, all of us are working together on this. We all want this to work as best we can. We're sharing information daily, and we have those really strong connections with Ottawa, and they tell us, and you can confirm it with them, but they do tell us that the new production facility that Pfizer has brought online is working well, and that they are confident that they're going to get the doses that they've confirmed between now and the end of April. We also understand that the ongoing modifications that were made in the Moderna plant means that they are able to ramp up production, not just for Canada, but for global good. And we know that there are some other vaccine candidates that were not successful in early trials. If you remember, months ago we were talking about 159 trials that were started in phase 1 and phase 2, and there's a number of them still, a couple dozen that are now in phase 3 trials. So there's likely to be more vaccine in the near future as well, which is good for all of us, because we are not all safe until every country is protected, and that's also really important. So the short answer is yes, we're confident relatively confident. We can't always say for sure, but we are confident in the doses that we're getting this week and in the next few weeks, and we're ramping up to meet that need. The nice thing about the Astrazeneca is that it is a fridge-stable vaccine, which means we can use different, more flexible distribution systems. So yes, I know that some of the expiration date will be late March, early April, and we will use whatever we can get because we know that it's going to make a difference.
Follow-up, Richard?
Thank you. I'd like to ask for a colleague on the BCHL. Where does the proposal now stand, considering that they have played a number of exhibition games, all doing so well, traveling without a single COVID transmission issue? They've proven they can safely play under guidelines, so why not approve, if you haven't already, for that league to get back underway?
Yeah, so it's not a simple question. As you know, the guidance that we had, the safety plans we had in place prior to November were not adequate in a lot of different scenarios because we saw that this virus started to transmit a lot easier during the colder winter months, and we're still in that period. So what I've put together some time ago, back in our restart days in March or April and May last year, we pulled together a team of public health inspectors, medical health officers, people from WorkSafe, people from Sport, to look at different aspects of reopening. One of those was a key one around sport. And they're the ones that provide advice to me around whether we should accept variances or not to the gatherings and events order. And they do consultation back and forth with the different leagues and provide advice on where are the areas of concern. And right now they are continuing to work with the BCHL and with our regional teams because the plan is dispersed around the province in a way that's slightly different from the Western Hockey League, for example. So that is still in the consultation process, and there have been a number of concerns identified. I'll be blunt about that. That need to be addressed before that can happen safely. And I know timing is an issue, and whether those can be worked out or not, I am not clear.
Marcella Bernardo, News 1130.
I have to follow up on Richard's question because I need to know if the WHL has been approved now, because we're already reporting that they're planning to start up again at the end of March. So if you could clarify whether or not the 5 BC teams in the WHL will actually be playing games in Kamloops and Kelowna later this month.
That's correct. The Western Hockey League has been approved. We were talking about the BCHL.
Now, follow up, Marcella.
Okay, and so just to follow up, a completely different question. School safety heading into spring break, and have you given any thought to, now that we have so many variant cases in hot zones in the Fraser Health region and in the Lower Mainland, have you given any thought to possibly starting spring break sooner, sending kids home earlier in places where there seems to be a lot more exposures linked to variant cases?
Have I given any thought to it? Of course. Have we been consumed by worrying about these issues? Yes. And we know for some school districts, March break starts earlier. The main focus is the 16th, starting the week of the 16th. And yes, we've been speaking a lot with the school districts. Dr. Gustafson from my office and the BC CDC has been engaging with the schools. We've been looking at Parks and Rec. We've been looking at, how can we find safe places for young people to have activities during March break that they can socialize some more, but do it in a way that is safe. So we are looking at a whole lot of things. It's not an easy question. Timing of when schools start and and restart and when the break starts is all with the Ministry of Education. We are also working very closely, and Fraser Health is working very closely with particularly the Surrey School Board, Surrey School District, to look at what are the issues in the schools, how can we enhance, protect, do the things that we need in that district to address the high level of transmission in the communities that, again, as you mentioned, is reflected in the schools. Part of that, of course, is doing extra testing around people who are infected with these variants to make sure we can stop transmission. Even if we don't know how they became infected, we can ensure that we're not getting rapid takeoff. That is what we're focusing on right now, focusing on where we were. If you think back to March of last year, when we were talking about how important it was to do contact tracing both backwards and forwards. So making sure we try and understand as best we can where things are being transmitted and how and who, so that we can absolutely ensure that we're not allowing transmission to take off. That's been our focus right now. If we look, though, at school breaks, where we see transmission increasing in school-aged children is when they're not in school. So that is something we need to take into account as well. So all of these discussions are definitely going on, and we will have more to say about that in the coming days and week. I say week because it's coming up very quickly for many.
Next question is from Cindy Harnett, Times Colonist.
Thanks very much for this. Can you offer further detail into the instructions to health authorities this week, Island Health, for instance, on when they must cancel the second doses and for whom they are canceling the second doses? For example, I guess people in long-term care. And is the idea to turn some of those second dose clinics that are canceled into first dose clinics for others?
Yeah, so as you know, the discussions around this have been ongoing as the evidence has been building over the last week, really, when the studies from the BC CDC, from Quebec, and the National Advisory Committee on Immunization was meeting last week. So we did have discussions about this over the weekend. We had discussions about, is there some people where you should make sure they have a second dose for their own individual protection? And really the data showed us that even those most vulnerable, people in long-term care homes, had that really high protection after a single dose. So it was felt by the immunization team that there is no need for anybody right now to need that second dose, and that we needed to stop them as of when we made the decision yesterday. And so every dose today that would go to a second dose is now going to protect an additional person in our community in the high priority groups. So the decisions were made to pivot across the board, because there is no evidence that suggests that one person more than another needs that small bit of individual protection, and we do better by everybody by spreading those doses to other high-risk people. So that was the direction given to all health authorities, and some clinics were switched to instead of having people come in for second doses, they were able to bring people in for the same vaccine to protect more people in that community. And I know that's happened in a number of communities, but it a little bit depended on logistics.
Cindy, do you have a follow-up?
Thanks very much. I wonder if you can describe a little further. I'm taking it that a pivot is a major one for many of the health authorities. And with the accelerated timelines, what would that mean with respect to long-term care? Would we maybe see the increased visits move up sooner too, and if so, when?
Yeah, so this is the positive thing. We are not saying that everything else stays the same, that you have to wait for a week after your second dose before you're allowed to do those things. We're now saying that evidence shows us that that high level of protection is there, at least in the short term, after one dose. So that does move up the timeline for us to be able to increase visits to long-term care. We're focusing on ensuring that essential visitors are immunized, and that we are doing our best to protect people who go into long-term care, because we still want to make sure that it is safe for everybody in those environments. We've already, thankfully, seen increased activities within care homes because we've had such a high immunization level in care homes, and for quality of life, that is so important. But yes, we expect within the next, before the end of this month, to be able to increase visits and have families be together with their loved one in care homes. I know this is something that's important for us.
Yeah. And this is something we're working on now, and I think Dr. Henry made this clearer when she spoke of it yesterday, and it's something that's very important to us, obviously, is to address and increase and try and provide some, it won't be a return to normal, it can't be a return to normal during the pandemic, but a return to closer to normal, which is what we're looking for. And so that work is being done and has been going on throughout the pandemic and is accelerated now. So we'll be working on that. Just to put it in context, that's 196,654 first doses and 86,537 second doses. So it's approximately 110,000 people who have received first doses who would be following the new guidelines and the new situation, having a second dose delayed. But the good news in that is a lot more first doses, a lot more places we can keep safe. I'd also say that at the moment, the majority of people in long-term care have received second doses as well, a majority of residents, a majority of staff, because that's been the plan we've been going on up to now. And the response in long-term care, the 69,000 residents and staff, the almost 6,000 essential visitors, the 15,000 community healthcare staff, in addition to that, the 60,000 frontline staff people who've received immunization, that's made a real difference. And you can see that in the outbreak numbers, and you can see that in the quality of care. We still have some work to do in making our healthcare institutions safe, particularly in acute care. You saw some number of increased outbreaks in acute care because in that case we have people coming in and out of the facilities, new patients, obviously every day. So we're working on those issues as well. But in long-term care, a lot of progress has been made in the last number of days and weeks since we've begun the immunization campaign. You see it in the numbers, and we're obviously going to be working to make changes to make life better there, and that's really, really, really good news.
Katie DeRosa, Vancouver Sun.
Hi, Dr. Henry. I'm just wondering, you had said yesterday that essential workers could opt for the Astrazeneca vaccine if they wanted to get vaccinated sooner. I'm wondering about vaccine choice for the general public. When it gets to phase 3 and 4, will members of the general public, if they're, say, offered Astrazeneca, could they decline it and wait longer to get the other two, or what is the level of choice available to the general public?
Yeah, so let me be very clear. The vaccine you are offered is the best vaccine. All of the vaccines that we have available for use in Canada are safe and effective, and a single dose provides good protection from all of them. And we will be continuing to monitor that. The difference that we have, we've built the foundational part of our immunization program on the two vaccines that we have the most of early on, and that's the Pfizer and Moderna vaccines. So if you are in our mass clinics, those are the vaccines we'll be using. And no, you won't have a choice between Pfizer or Moderna. You'll take the one that's there in front of you, and I encourage everybody to take the one that's there in front of you. When it comes to the additional vaccines that we are having, the advantage they have for us is that we are able to be more agile in how we use them because they are stable at fridge temperatures, which means we can go into more places in the community. And we know from modeling studies and from the data that we have about who's transmitting to whom that some of the key areas that we can use immunization to help stop transmission in our communities, that gets us to the end of the pandemic sooner. So that's why we're talking about focusing vaccines vaccine on some of the essential workplaces where people cannot work from home, where we've had outbreaks in the past, and of course on first responders who have been out there on the front lines every day and are at risk because of their job of spreading it between each other and having to isolate and the administrative challenges that provides as well. So that's where we will be targeting this more flexible vaccine early on. And so there is a bit of choice. I would not suggest people wait. These vaccines are all good and they all work, and we've seen that across the world. So the vaccine that you have is the best vaccine right now, and we'll be coming out with some more details. We're looking at the numbers and where we can have the best impact, and some of the modeling about who's transmitting to who, to help us look at the limited number of doses that we have to begin with the Astrazeneca vaccine.
Follow-up, Katie?
Yes, but is it still accurate that the AstraZeneca vaccine will not be used for anyone over 65 because of the limited clinical research?
Yeah, it is approved for use by Health Canada, but our program here in BC is to focus it on the younger age groups because we have a very strong program based on age, and we think that the timing for people in their 60s will be in the next few months, whereas we know that if we can target younger people who have more social interactions, who would have to wait much longer for the Moderna Pfizer vaccines, that we can make a greater impact and protect more people in that sector. So our program will be targeting at younger people, yes.
We have time for one more question. For everyone listening, Dr. Henry and Minister Dix will release a statement this afternoon with the latest information on cases, hospitalizations, and outbreaks, which you can find at news.gov.bc.ca. For updated province-wide restrictions, visit gov.bc.ca/COVID restrictions. And for information about the province's orders and pandemic supports, visit gov.bc.ca/COVID-19. Last question today is from Tanya Fletcher, CBC.
Dr. Henry, you mentioned widespread easing of restrictions will happen when we see slower spread and ramped up vaccines, but our new case numbers have kind of stalled or plateaued for several weeks now, despite the vaccine getting into people's arms already. So is there a more specific benchmark you'll be watching for on that front? When should we expect daily caseloads to reflect the vaccine effort, aside from the success in long-term care homes we've already seen?
Yeah, we've been, we think it's a lot, but yes, we've been targeting those high-risk areas where we're seeing outbreaks, where we knew people were being hospitalized or dying. So, and we've seen the success of that. Doing that on a broader population basis is going to take more time, and that's why we're looking at how can we strategically target some of those other settings where we're seeing outbreaks, and that will help reduce the risk of transmission for all of us in the community. So it does build up over time, and the things that we watch are that rolling 7-day average, because we know that due to the way our lab system works, some days we have more cases than others reported, but it's much more important about when people when their onset of illness is, and that's the epidemiologic curve that we look at on a regular basis. So we will be targeting vaccine to see if we can affect that as well. So rolling days, 7-day rolling average, where the outbreaks are happening, looking at our hospitalizations and our and people in ICU, that's a really important metric that helps us understand if we're immunizing the right populations, for one thing. So and the other thing that we keep learning about this virus, we're learning about the variants. We're focusing a lot of our attention on case and contact tracing to make sure that those variants don't take off. That is my biggest worry right now, and I've said that repeatedly. We are in that strange period of trying to understand how many of these we're seeing and where we're going to, and trying to stop any sort of rapid increase. We've seen from the modeling that that's what's projected some places, but we believe we can affect that by the measures that we have in place. And we know that once we get into spring, the transmissibility overall will go down a little bit. So if things go well, if we're able to even hold our line or keep it preferably decrease it, hit some of those hot spots. By the time we get to even early April, we may see some limited ability to increase interactions. But I really think that we're looking at the summer getting back to a lot more of the things that we need in terms of social interactions, in terms of the sports and theater and other things that we are missing in our lives.
Follow-up, Tanya?
Yes, thank you. We're hearing from some First Nations leaders who are saying there's a lack of clarity about vaccine allocation since an unexpected change to the vaccine rollout plan last week. They're also seeing, they say, an inequitable distribution between communities where some appear to continue to get vaccines for the whole community while others are being told their allocation is limited to specific age groups. Any insight into why that's happening, and if we could get an answer in front as well, please? Thank you.
You know, this has been a priority for me and for us in our immunization program from the very beginning, and we have we've worked very closely with our First Nations partners to make sure we've identified those remote and isolated, to start with, the remote and isolated communities, and take an all-of-community approach. I will say that during our period of time in January into February, where vaccine was strictly limited, where we had no supplies coming in, particularly of the Moderna, and most of the vaccine that we sent to the remote isolated, and then increasingly providing immunization as available to First Nations communities in areas all over the province. It was Moderna vaccine that we were relying on, and we had a number of weeks where we had very little Moderna vaccine. And we had to make the decision with our First Nations Health Authority partners to focus on protecting as many elders and seniors as we could in that period of limited vaccine. I can say that we've been in discussions now about how important it is now that we have delayed the second dose. That frees up a lot of vaccine that we can get back to the whole of community approach. And do you want to speak to that in French?
And just to say, Tanya, I mean, I understand that consideration and that concern from some First Nations communities and others, but I think the decisions made this week and the path going forward and the extraordinary effort everyone's made together over the last few weeks are really going to be, I think, very positive. And so, yes, there are some communities that had a whole-of-community approach, and others where we were much more working with our partners, targeting immunizations to those who are most vulnerable. That has occurred, and now that we've freed up some access to vaccine, we'll be able to continue on with more of a whole-of-community approach, and you'll be seeing that in the coming weeks. Je dirais en français que nos communautés Premières Nations faisaient une partie essentielle de notre plan de vaccination en Colombie-Britannique, à peu près 20 000 immunisations directes dans des communautés partout dans la province qui sont pour la majorité rurales. On a aussi utilisé ces vaccinations pour répondre aux difficultés dans des communautés particulières, y compris des communautés comme le NACI, comme le Cowichan, etc. Donc, on est à un nouveau moment actuellement, c'est-à-dire un moment où on a ouvert un peu notre capacité de livrer des vaccinations un peu partout. Et je pense qu'avec nos partenaires dans la FNHA et d'autres, on va réussir à continuer nos efforts, mais à améliorer et à augmenter nos efforts dans ces communautés. C'est absolument essentiel. Les efforts des communautés des Premières Nations, des communautés autochtones, des communautés un peu partout dans la province, l'effort dans ces communautés est très important dans la mesure où nous avons vu beaucoup de cas, beaucoup de transmissions récemment, pas au commencement de la pandémie, mais surtout récemment. Et il va falloir répondre à cela. Et je pense que notre campagne, dès aujourd'hui, va améliorer et augmenter nos efforts dans ce domaine. Merci beaucoup. Thank you very much. We'll see you on Thursday.
Thank you for joining us.